Great. Good afternoon, everybody. I'm Dilkash, together with Lorenzo Grispan and Shiraz Hari Prasad. We're going to be presenting today on HIV and together the three of us are from Stretchford, CHC, and Orange Farm. We know that it's quite a large topic, so a few of the things we're going to be discussing the future HIV topics in the coming weeks. Okay, just starting off with a quick epidemiology of HIV in South Africa. Is a table by Stats South Africa. It shows us the prevalence and in Africa for the last 19 years, since 2002 to 2021. It shows us here that we currently have 2-3 million people with HIV. 0.6 our current the prevalence over the last, as well as incidence being decreasing. This is made with HIV treatment and testing, leading to less HIV-related deaths, as well as prolonged expected life ages, as well as less HIV infection occurring. This second table results from a study that was published in BMJ in April of 2020, which aimed at generating high resolution maps showing South Africa. It shows us the with HIV within each province and splits this table further into males and females, divides that again into each province. As we are in Gauteng, it showed that we have the largest HIV with 26% of females and 29% with HIV just being in the Gauteng province alone. It showed that we have around 0.5 and 0.47 health per 1,000 people living with a respective gender. Emphasizes the strain as well as available to these HIV positive patients. And I'm now just going to hand over quickly to my colleague Shiraz.
Thank you very much, Dilkash. Anatomy and pathophysiology of the Okay, so visualized here is our human immunodeficiency classified as a retrovirus. So structurally, it consists of a biphospholipid envelope externally with a number of glycoproteins on its surface, most importantly GP120. Within is the which contains the RNA as well as reverse transcriptase and integrase. In the human body, the binds to macrophages via the CD4 receptor, as well as the COR5. This cell through the process of releasing the nucleocapsid and its contents into the cell. Once within, transcriptase enzyme converts RNA into a single strand of DNA and subsequently copies the into a complementary DNA DNA particle. This cell's nucleus and is integrated into the host cell's DNA by integrase. As the host cell processes, messenger RNA is produced and viral proteins are produced by ribosomes. Then the host cells and completed viral particles are released into the visualized here. Over time, for the G take place, this changes its affinity in CD4 cells, susceptible to bind to 4 co-receptor, which will be shown shortly. 4 T cells So the HIV virus rather binds CR4 on T cells, replication process. The major difference in this case, however, is that when particles are released, they in fact by killing. This results in the common manifestation that we all know. So we'll be going through.
Cool. Let's go to the next slide. So as I'm sure many of you have already at some point hospitals, these are the tier.net forms going to the HIV management and surveillance in South Africa. And as Dilkash has mentioned, because it's a very different angles that you can approach it, we decided to form along these kind of documents in front of you, from diagnosis and management, surveillance, and to the current COVID. So just a quick note before we move on. At the product of obviously the healthcare or the individual person filling them out to do, it's quite important, and you'll see why the slide off at the very, very basics. The testing, you can see here, we have a different variations of the HIV rapid antigen test here. Break it up very simply. The first line at the top, which is the red tinged line, is the control variable. In any test that is lit up, test that is classified as an invalid result as test in and this obviously results wouldn't be done. In the event of a test not having the preferable to check the expiry date, which should be done prior to the but tests have arrived. When a control there are no other tests on the rapid as seen in figure, that is a HIV result. So is a negative result. No is a invalid result. Control variable positive, red tinge line positive. Afterwards, subsequently, be it a faint tinge or a double strand in A, single strands in B, C, results for the HIV-1v2 virus. All right, and onto here. A little bit further onto the different testing modalities is a nucleotide amplification tests. And what we can see here is that usually a detection around the 10 to 33 day an antibody test, as described here, can be seen and pick up results around the 18 to 45 day antibody test are usually seen to do the result 90-day mark. This is exactly what, as you can see, the test of a greater result. I'm just going to move this. Is the HIV, the P24 in the HIV antibody test. Okay. While we're on this topic, it also has a positive test result. So I'm going to just go back to the slide. Person has a positive test result. So in this case, being B or C, sorry, F and G as well with the faint lines. Another test. So you've had one rapid with a different manufacturer, preferably from the diagnosis. You will move on to the serological investigations. Right. Now you have a positive test result. What's next? According to the tier.net forms, is a classification, as I've mentioned or described here, there's stages we're all aware. I've included the CD4 counts, which are not common the CDC recommendations. However, we follow a symptom-based approach, as you can here. They are found literally just need to go in a stepwise if the patient is exhibiting any symptoms of these conditions. Okay. Taken, you need to be cognizant of the fact that once a person has been classified, be it 1, 2, 3, or 4, they are no longer only move forward. So if I, let me see if I can draw from stage 2 to stage 3, stage 4. The only place you can go is forward. And once it's received a classification, it is a classification disease progression. Let's put it that way. Okay. Let me close this. Okay. Is just two visual representations of just the dual modality that the tier.net forms have. Not only do they a marker for individual patient management, but they're also able to purposes, as what Dilkash has mentioned in the first. So these two slides have come from a article that was published in the province. Different modality that they are using in the particularly in the picture that you is TCT, and in the adult. So those form the backbone. This is why I mentioned earlier that it's important to make sure on the individual documentation not only read by other people, at the same time can be collated to form the statistics that we. And on the right hand side is more of a flow diagram as structured in terms of their relating all their statistics. Tests. I heard a couple of us maybe have positive patients come through to us and we were of the disease. There are a variety of tests that are available that are, and the next slide in red are the ones that South Africa. As you can see, what has been HIV serology, viral load, and Hep B screen on diagnosis of, which should be done, but preferably within the test diagnosis. CD4 count 3 to 6 months, yearly thereafter, or in the event of a treatment that is done clinically indicated, whereby the patient exhibits the stages 2, 3, and 4. The viral load to be done every 2 to 3 8 weeks, 3 to 6 months every month, and failure. We adopt a different protocol. We do the viral load. We then subsequently do not, because we concern ourselves with the viral load thereafter, because it's not really an indicator. Progression is what we use. Just a reminder again, done on, sorry, until such time that 200 or viral load is less than 1,000 testing. 6 and 12 months utility and upon or treat resistant testing, HLA. Okay, these are not done is only done line treatment, not done in South Africa, not used in our setting as a monitoring tool for a patient has hepatitis determined by positive surface antigen test or should be used as part of the regimen. Okay. The other test. Okay. In particular, creatinine from the US or CDC recommended. You do not do it at 2, not every 6 months, again, because of resources. Also follow up at different times. Serum creatinine months. And again, there's no effects to the medication, which can thereafter be monitored. DLT, total blood profiles, glucose, urine monitoring tools, usually and modification of okay. Where now there's a, although there is the tests are not, we should be screening for baseline clinical evaluation. Infections will be covered in, but upon initiation of a patient viral treatment, there should be as a TB screen. I'm sure of our healthcare symptoms, which again fall parts of infection, depression, and other non-communicable diseases. So this a person would then do a file just to assess whether or not the person is afflicted with any that can be a pregnancy as well, and screening for STIs. Then on this slide, as a group, and we're quite quite excited about correlated antiretroviral treatments that we've seen at is now again open to if anyone does see any other treatments that they are able to, please send them through to me and I'll add it to our document. I made this PDF now, but what we've essentially done is tabulated all the different patients come through with, where there is on the, sorry, a little bit further on, we'll see the actual medication that the patients are taking, but like patients are starting to not know taking their medication. Some people say that they or one tablet at night, or they take the little pink tablet, and as we know, there are multiple different agents that have the same color frequency of tablets. So this is just a quick guide of what the tablets are, their names, and what they, I mentioned before. Please do feel free to show them to their patient, and it has made the treatments of the patients that would be on first line tenofovir and emtricitabine. Instead, they've been changed to the dolutegravir regimen, the dolutegravir containing regimen by the Atroiza and the triptygan bottles. So hand over to Shiraz to continue. Thanks.
Thank you, Lorenzo. The management of HIV. Obviously, it needs to be multidisciplinary and multifaceted manner. Goals, outcomes that we aim to achieve virological suppression and then immunological reconstitution, to manage all opportunistic infections. This point, of course, I will leave to our colleagues this topic next week, but I'll be focusing on our first, which is virological. So in order to achieve virological, employ antiretroviral. So listed in this table are the various available that we have. So just going through nucleoside tryptase inhibitors, non-nucleoside reverse transcription protease inhibitors, sake are, and then not as commonly inhibitors. The diagram on the right-hand side of the screen depicts the various levels at which the in the replication cycle. This table over here, as Lorenzo was mentioning, has pictures that are generally available together with our group later to identify the drugs that your patients might be using. So in terms of starting, and as mentioned, in South Africa, we use a combination of antiretrovirals in order to in general, the guidelines say the following. So first of all, if possible, obtaining your CD4. Patients may be initiated if contraindications exist and appropriate. However, there are special indications where one may times. So immediate initiation is required in all pregnant and breastfeeding women. In terms of this is done in a count of less than 200 unless there is any sign of TB or cryptococcal meningitis, eligible for deferred initiation, and again in a later lecture. In terms of that are used, so currently, are moving towards an INSTI-based regimen. It's 2 NRTIs as well as Jhb combined with tenofovir and limivudine. That we no longer write Atroiza on our scripts, Atroiza. Second that is available is our old regimen combined with tenofovir. Goes through the various contraindications and how. So first of all, if a patient is on a tenofovir, tenofovir is nephrotoxic. Patients who have an EGFR less than 50 millimeters per minute, worsening renal function, either abacavir or zidovudine. The second drug that we commonly use is AZT, so zidovudine, and this is contraindicated is anemic or neutropenic. It's in patients with psychosis, although side effects, and these dolutegravir also cannot be switched to dolutegravir. These patients can lopinavir with boosted ritonavir. So a big thing nowadays. So we'll just brief. So recently, Department of Health has approved dolutegravir for use in including pregnant women. Confirmed that there is no significant increase in the risk of neural tube defect. The benefits of using efavirenz is a much better tolerated side effect profile, which is which is much more self-limiting. Virological suppression than with efavirenz, and the DTG has a two mutations. This table from our South African guidelines outlines actions with dolutegravir. Of note is so on our TB patients who are using rifampicin. Rifampicin, as we know, is a CYP4 initiator, and therefore that would decrease dolutegravir. And cations and anti-note carbamazepine and phenytoin the same effect on levels of dolutegravir. But higher weight, tiracetam, and pyramate don't have this effect for use in these patients. So in patients, we can then double the dose of dolutegravir to 50 milligrams. The second metformin, DTG increases metformin. We need to maximize our metformin dose 100 milligrams 12 hourly. And then just a note on the management of virological failure. So as was mentioned by Lorenzo, we perform viral load monitoring months and yearly thereafter. Based on these results, we can divide our patient degrees. So here, green, orange, and viral load of less than 50. Orange 9 and 1,000, and red being to 1,000. So if your viral load is great and you can continue routine management, the orange and red category. So at this stage, it's important that we don't virological failure. We need to do the ABCs of HIV, attempt to identify problems, and then look for causes for reductions in levels, that being intercurrent infections or bugs, the patient, drug interactions, and lastly, to keep in mind resistance but not diagnosis at this point. So doing the above in 3 months. At this stage, viral load reading of between 50, we call this a viral blip, and no means for the outcomes of patients. Too much of a concern when you have a single reading of between 50 to 1,000. So as mentioned, we then repeat our viral load and find our patients. Viral load less than 50, or we again have a viral 99. Continued adherence, trying to find this low-level viremia. So at 2 readings, 99, we now term this low-grade or low-level viremia. Have a low-grade viremia, we can then discuss possible need. For those who have persistently high viral loads exceeding, our management is asked which regimen the patient is on. If the patient is on our NNRTI, so efavirenz-based regimen, consecutive readings clinches the diagnosis of virological failure, and we then will change regimens. On our current dolutegravir-based regimen, so lopinavir, one cannot diagnose virologic 2 years of having started treatment. Drugs have a high genetic resistance. So it's important that we rather have 3 readings exceeding 1,000 copies per mole over 2 years of clinical immunology. Essentially summarizes how we so looking for again, as we noted currently in calculation, it's important in general to know with regards to a resistance, do not perform resistance. Additionally, it's important to hepatitis status. All patients who are hepatitis positive, them on their tenofovir and not remove that, as that in essence, so for zidovudine, which is AZT, and dolutegravir. However, if dolutegravir is not suitable, ritonavir. It's important to note that if they're positive, we actually don't change the tenofovir. We keep tenofovir as. Then moving on to our second line regimens. So once the patient has been switched, and again we find them having continued virological failure, then we then consider the following. So again, this is a stage where we perform it. We now need to determine exactly what susceptible to, and we refer them to the third line committee for further management. I will now be handing over to Dilkash, who will end off our presentation.
Dilkash, you'll have to do it a little quicker. Unfortunately, time's a bit not on our side. Go for it.
A few things regarding HIV. Had a few patients at questions regarding their vaccinations and how COVID would affect them personally. A view from the CDC in America, they recommend that people with HIV get vaccinated against COVID-19. Also recommends that people who have gotten the Pfizer or Moderna dose of the vaccine 28 days after their original doses were. However, do not have enough information regarding the J&J that we've currently been giving out in South Africa. They've also mentioned that use showing the use of ARVs for the prevention of COVID-19. Regarding, they've taken in 2021, and they've suggested that there is an increased risk of severe disease as well as higher risk of mortality if patients with compared to HIV. They've also seen that two comorbidities such as hypertension and type 2 diabetes worsen risk of death with COVID infections. They evaluate the evidence regarding this continually, however. They have also seen a reduction in at healthcare sites worldwide. They recommend that HIV positive people vaccinated, and have said that are safe for people, provided the recent evidence suggesting a higher chance of positive patients. That was done in KZN, which looked at, published in the Lancet HIV journal in February of this year, and it an interrupted time analysis of 65 healthcare area, which in Durban as well. It shows that there a reduction of about 7% in a 46.2% decrease in HIV initiation since lockdown has started. There's also been a slight decrease in medication collection noted as well. These are two graphs that would shows quite a showing the levels of each lockdown and decrease in the HIV number of tests from ART initiate down stage. These are two other graphs that also suggest similar decreases in ART collection in healthcare facilities during the lockdown periods. This from written by Professor Mardi and Professor Glenda Gray. These the HIV journal as well, which has data throughout 2020 and how COVID-19 has chronic comorbidities. It shows a decrease of testing, as well as a decrease in about 33% of our CD4 count testing, which we should be HIV positive patients. We just wanted to have a word on the potential of HIV vaccine. We know it's quite an interesting topic, but the I wanted to speak about was that there was a recent human trial of about HIV negative participants that is which is based off the COVID-19 vaccine, is the mRNA developed during this COVID pandemic, HIV, which aims at targeting to broadly produce antibodies against the HIV and CD4. However, we are still information regarding this citing be discussed. And yeah, that's it from.
Thank you. Well, while you're giving the colleagues a bit of a rating of their presentation, I think it's really good. I think that there's lots of very useful information. I'm glad that you focused it in a way that you thought what's best to provide to my colleagues. And I think all of you should take cue from that kind of approach. You know, think of it in a way that you think will add value. I want to also urge, please, we'll have to keep these presentations strictly to 25 minutes to allow a little bit of question and answers and just a little bit of spread. So do some timing on it. And unfortunately, Lorenzo, you did some really good stuff, you guys as a team, and we were struggling with your voice quality. So I think lots of people found that challenging. I did. Please, everyone, can you please make sure that you test your connections where you are and that you see that it works well enough. It would help if you send me your presentations, because sometimes that alone might be making your connection challenged. So even if you only need voice, that can work better. So please, as a routine, all of you send your presentations to me. So if there are challenges like this, I could have actually put up the presentation and made the voice quality better. So here we are. You can see, thank you. Your colleagues feel that you've done pretty well. And great to you guys. So let's move on quickly. I don't know if there are any other questions or comments. I don't see anything and we don't have enough time, so sorry, but we'll make a plan. I think, thank you very much once again.